So the Calgary chapter of the Canadian Liver Foundation, which is located in the heart of southern Alberta, both acknowledges and pays tribute to the traditional territories of the peoples of Treaty 7, which include the Blackfoot Confederacy, comprised of the Siksika, the Piikani, the Kainai First Nations, the Tsuut'ina First Nations, and the Stoney Nakoda, including Chiniki, Bearspaw, Goodstoney First Nations. The city of Calgary is also home to the Métis Nation of Alberta, District 5 and 6. So I'd first like to welcome you, and I, of course, would like to acknowledge our wonderful sponsors of today's event, which we could not do any of this without them: Bristol Myers Squibb, Nova Nordisk, Ipsen, GSK, EFW Radiology, Alberta Blue Cross, and Bayer. So if I can get a little round of applause, that's why we all get to be here. Thank you very much, sponsors. And there will be a little survey available for you to fill out after. Those will be available on the front table this afternoon. If you don't mind filling it out, it helps to give us some insights on how we can make this bigger and better moving forward. And first, let me tell you a little bit about the Canadian Liver Foundation. The Canadian Liver Foundation was founded in 1969 out of the compassion and concern of a committed group of business leaders and doctors who believed that liver disease needed a champion. Our mandate is to promote liver health, public awareness and understanding of liver disease, reduce the impact and incidence of liver disease by providing support for research, education into the causes, diagnosis, and prevention and treatment of all forms of liver disease, while providing support to individuals affected by it. Our vision is a world without liver disease. Without further ado, I would like to introduce our first speaker, Dr. Mark Swain. Dr. Swain is a hepatologist and professor of medicine at the University of Calgary. He holds the Cal Winslow Family Foundation Chair in Hepatology. Dr. Swain has long-standing research and clinical interests in improving the management and treatment of people with metabolic, viral, and autoimmune liver disease. With a specific focus on liver disease-associated symptoms, he is the president of the Canadian Association for the Study of Liver, CASL, and was inducted as a fellow of the Canadian Academy of Health Sciences in 2019 for his accomplishments as a clinician and researcher in helping to improve our understanding and management of liver disease. So please welcome Dr. Swain.
Thanks very much, and good morning, everybody. Here we go. So I'm going to talk to you this morning about MASLD, which many of you might know as NAFLD or NASH. I'm going to talk a little bit about why it's called MASLD and why that name change happened. And I'm also going to talk about some of the treatments that are coming along that are actually very, very close to being launched. And in fact, one of them has actually been launched in the United States. So what is fatty liver or steatosis, and why this is important? It's important to understand what's going on in the liver and fatty liver disease, but it's also important to understand why the name is being changed. I mean, so when people talk about fatty liver or talk about it, I must say I still use it a lot because I think it's easier for people to understand what it means when you're talking in the clinic. But the shift is away from fatty liver disease because it's felt to be stigmatizing, and into steatotic liver disease. Steatosis is just a fancy way of saying fatty liver, right? And so what is fatty liver? Well, really what it is, if you look at on the right-hand side of the screen, it's the cells in the liver which are, they're kind of like a virtual liver that hasn't been blown up, essentially. But what happens in fatty liver disease is that those cells get blown up with fat. They become like a balloon that's full of air rather than air that's full of fat. And so this is what it looks like. That whiteness that you see on the far right, that's fat inside the cells that are puffed out. And when you look at an ultrasound, so when someone says, oh, look, I'm going to send you for an ultrasound to look at your liver, what they're doing is they're shining a sound wave through your liver. And so when you start to look at the difference, so the upper left-hand side, that's a normal liver. You can see in the bottom part, there's sort of this white kind of thing. That's your diaphragm, your big breathing muscle at the bottom of your lungs, which is just above your liver. And this is your liver here. You can see that you can see all the different parts in your liver. So if you had a mass in there or something like that, they could see it in the blood vessels. As you get more fat, it starts to get this white shadow look in it. And then you get more fat, you actually start to not be able to see the back of the liver. See how it's sort of dark here? Can you see that? Oh, I guess you can't see that. It's sort of dark, so on the bottom left, you can sort of see that darkness where you can't actually see the liver anymore. So if there was something in there, you actually couldn't see it. And then you look at the bottom right, you've actually completely lost it. You can't even see the diaphragm. So this is how they grade fat in the liver, or steatosis in the liver when you get an ultrasound. And why it's important is that if you're actually doing it to look for something in the liver, something you're worried about, you're not going to see it very well if you're down the bottom right. So what are the main causes of fatty liver? Well, there's multiple different causes, and I've listed them all here, but the main drivers of steatotic liver disease or fatty liver disease around the world are really relates to diabetes and overweight and obesity. And actually, this nomenclature of being called MASLD actually comes from this guy Ludwig at the Mayo Clinic back in 1980. He was a very astute pathologist, and he was seeing cases come to him that looked like alcohol-related liver disease when he looked at them under the microscope in a biopsy. But these people said, I don't drink, I've never drank. And so he was trying to understand how they could have a biopsy that looked like alcohol when they never drank. And so he called this non-alcoholic fatty liver disease, or NAFLD, or non-alcoholic steatohepatitis, or NASH. And it was really felt to be a diagnosis of exclusion. So basically, you would rule out all the other causes with all the tests we do, but then you'd also you would ask, do you drink alcohol? And there was a cutoff that they kind of used, of sort of 2 drinks for females, 2 drinks for females, 3 drinks for males. If you went over that, then you were felt to be maybe into the alcohol-related liver disease, and then they wouldn't use that term NAFLD anymore, or NASH. And certainly there's evidence that no matter what kind of liver disease you have, alcohol can make it worse. And so the more alcohol you drink, the more chance you have of making that liver disease worse. But obviously, with non-alcoholic fatty liver disease, or NAFLD, and alcohol-related fatty liver disease, which look the same under a microscope, that's why Ludwig was confused. If you have both of those happening at the same time, well, of course, that's going to augment the damage to your liver, potentially. And so, how this whole name change really started to take its head, it was this concept of stigmatization related to fatty liver, or the word fatty. But also the recognition that what drove fat into the liver, it's not just specific for the liver. Because if you think of diabetes and you think of overweight and obesity, these are systemic things. It affects all parts of our body, our heart, our kidneys, our brains, all of those parts are affected. So it's actually what we call a systemic illness, which means it affects the whole body. The liver is just kind of a part of that. And the liver reflects this metabolic derangement, which is part of what's called the metabolic syndrome. And these are the components of the metabolic syndrome. These come up quite often on news or TV or whatever, because they all drive increased bad consequences to our health. So high blood pressure, I think we all recognize what that can do. Diabetes, dyslipidemia is really high cholesterol or low, or like high bad cholesterol or low good cholesterol. And so all of these other components are all part of what is termed metabolic syndrome. And metabolic syndrome is really, when you look at overweight or obesity as a driver of this, because when you look at individuals that have a BMI above 30, and you follow them out for 5 years, they have a 20% chance of developing diabetes. So they're intimately intertwined, all right? But if you look at people and you look at their weight distribution, if you're an apple, so the weight is around the middle, that weight is worse from a metabolic point of view. That's more metabolically active, it makes more hormones, it leads to more inflammation in our bodies than if you're a pear shape. So if you have more weight on your bum, which is more of a pear shape, then those people, fat is less metabolically active. So it's less driving of the adverse outcomes associated with weight. And of course, when you're talking about alcoholic liver disease or non-alcoholic related fatty liver disease, the problem with liver disease traditionally has always been that people would come and see their doctor, and the doctor would say, well, your liver is abnormal, how much do you drink? And they'd say, well, I don't drink. And so, well, no, come on, how much do you drink? And so it would keep going on and on and on. So it was always this stigma that if you had liver disease, it was assumed to be alcohol. And so that really has held back a lot of progress in liver disease, because the attribution that all liver disease comes from alcohol. So its name change from MASLD to MASLD, which is still happening. I mean, nothing happens quickly or easily in the world of medicine and in the world in general. But the idea was to do a bunch of things, was to eliminate the word alcohol from it. So you're getting from NAFLD to MAFLD. MAFLD is metabolic dysfunction-associated fatty liver disease. And so basically, they're trying to get rid of the alcohol component. And so really, they wanted to take away from the negative connotations of alcohol and make it a positive diagnosis as opposed to a negative diagnosis. And so that's where this whole term metabolic dysfunction-associated fatty liver disease, or steatotic liver disease, which is MASLD, is the newer version of that. The problem with this, as I'm sure you all recognize, is if your doctor started talking about metabolic dysfunction-associated steatotic liver disease, no one's going to follow that. They're not going to understand what that is. Where most people, when you say fatty liver disease, at least we can visualize what that is. So it's going to take a long time, I think, to get this shift to happen in a way where it's easily usable in a clinical, when you're interacting with your doctor. So this is the old thing. The old idea was you had an apple. When you hit a certain boundary, which is that red vertical line, you shifted into alcoholic-related liver disease. Okay, it was this very strong, firm. It went from non-alcoholic fatty liver disease to alcohol-related liver disease. And for women, it was 2 drinks a day. For men, it was up to 3 drinks a day. And once you crossed that line, you shifted into alcohol-related liver disease. Whereas the new criteria has a new thing called METAL, which is essentially metabolic associated with alcohol-related liver disease. And so that you shift that red line to the right, and so it's the recognition that many people consume alcohol who have non-alcohol-related steatotic liver disease. And so the idea was to shift it so that for women, rather than having a cutoff of 2 drinks a day, they could go higher up to 5 drinks a day, and for men up to 6 drinks a day. And they would still be encompassed in this MET-AL thing. And only after that, if they went above that, would they become felt to be purely alcohol-related liver disease. And so the old nomenclature was based on how much steatosis or fat was in the liver. That's that one on the left. And the one on the right, it's really about more metabolic dysfunction. So this metabolic syndrome, the more of that you have, that drives you up further on that vertical axis. And then alcohol's on the bottom for the both, but you get away from this rigid cutoff and recognizing that there's an overlap that's very important to recognize. Also, it's when people go to get an ultrasound that have fat in their liver, often the report will come out, and it's going to be very important, because nowadays many people can go look at their reports in Connect Care, and it'll say severe fatty liver disease. And so people automatically assume, and many physicians do, that that's bad. Like that means that they've got worse liver disease. Well, that's not what it is. It just means they have more fat or steatosis in their liver, which actually means they have more metabolic derangement in their bodies. And in fact, if you look at their outcomes with the more severe steatosis or fat you have in the liver, actually the outcomes, what it drives are the more metabolically related outcomes, like heart attacks and stroke, kidney failure, diabetes development. Not so much the fat in the liver that you see, the quantity is not related to liver outcomes. They also think that this name change is going to allow us to study people differently, as opposed to looking at everyone as one big blob that has this type of liver issue. to divide them into groups that where, say it's more genetics that's driving it and less metabolic syndrome, or maybe it's more metabolic syndrome and less genetic. So you can actually start to treat people differently. More, you may have heard the term precision medicine. Well, it's really trying to treat people as an individual based on their risk factors, as opposed to everyone's treated the same because you're all given the same disease or the same name for it. And so this concept of precision medicine, you're going to hear more and more about it because that's where medicine is moving. It's trying to say everyone's an individual, everyone has their makeup, which makes them who they are, but also is going to A, make the disease behave differently in them, but also is going to make them respond differently to treatments. So how common is MASLD? Well, it's really parallels the MASLD. So this map is superimposable, but in Canada, roughly it's about 25% of the population, and it's growing every year. And so this is a huge number of people in the population of MASLD. And it really, when you look around the world, why people have MASLD, well, it's really related. It's the map of MASLD in the world is you can overlay it on the access people have to densely caloric foods and how easily they're obtainable. So when we have easy access to highly caloric foods, which we all love, MASLD parallels, because obesity and diabetes parallels too. And you look at the things, it's been a shift in our traditional diet, as we all know, and to foods that are high in saturated fats, high in carbohydrates, and easy to access. I mean, drive-through places to get food didn't exist 60 or 70 years ago, right? And so this concept of being able to get these foods so easily, when we go to the co-op or Safeway or whatever, they're everywhere. We can access them so easily. Also, I view it as a toxin to the liver. Fructose-containing beverages, we don't metabolize fructose. So if someone has a Coke, I have patients in my clinic, my steatotic liver disease clinic, that their only risk factor for severe liver disease, and they come in with cirrhosis, is they drink 4 or 5 Cokes a day. Fructose is toxic to the liver. It's a bad thing for the liver. And it's unfortunate that it's permeated our society so heavily because it's so sweet. We all love sweet stuff. But fructose is really bad stuff. And so even if I can get them to switch to a diet soft drink, and there's all this bad press about diet soft drinks, there should be way more bad press about fructose-containing beverages because they're highly caloric and toxic to the liver. And also we have more sedentary lifestyle. Our jobs are much more sedentary. And so when you look at the world of sort of overweight and obesity in Canada, you can see that the map, the US is way worse. If you go south in the United States, and you just watch the Kansas City Chiefs playing football and look at this in the audience, it's quite striking that it's going to be the health problem of the future. And I think when you see like the show with Oprah recently, I mean, you know, this is the whole concept of shifting. I'll talk a bit about those drugs too. And of course, where overweight and obesity goes, diabetes falls. I said, if you have a BMI above 30, you know, in 5 years you have a 20% chance of being a diabetic, right? So they go hand in hand. And if you look at the numbers, if you're diabetic or you're overweight, your chance of having fatty liver disease is very high. And even if you don't have those, there's something called lean fatty liver. It's really about people that seem to have fat deposition more in the middle, but they don't fit the criteria based on BMI of being overweight or obese. And they actually also have an increased risk of having fatty liver. That's about 1 in 4 of the population. So when does fatty liver become bad? Like when does it become a disease? Because in most people, fat in the liver is just fat in the liver. It just sits there. You lose weight, just like when you lose weight, say it leaves your tummy, it leaves your liver. In fact, it often leaves your liver first. And so in most of those people, they don't have liver disease. They just have fat in the liver, which is a reflection of their metabolism in their body is deranged. And so what happens in some people is that fat in the liver, these liver cells, which are like balloons, is toxic, very damaging. And so it actually kills those liver cells. And when it kills those liver cells, the immune system comes in, and that's the circle that says the immune cell infiltrate. It surrounds those dead cells and takes away the old refuse of those dead cells. So the liver is amazing. If you cut it in half, it just regenerates. It grows right back. It's the only organ we have that regenerates. So if the liver cells that are dying, if our livers can keep up with that, we don't get any scarring. We can do that for our whole lives. It's not a problem. But just like if you have a little cut on your hand or a big cuts heal by scarring because the skin can't heal that hole fast enough, so it throws scar tissue in. And so what happens in the liver is that the liver can't heal those liver cells that are dying fast enough. It fills the hole with scar tissue. And so it's the scar tissue that really worries us as hepatologists or liver specialists. And this is kind of what, so when you think of MASLD, it's not just one thing, just like precision medicine, it's just not one person. It's actually a spectrum. You go all the way from just fat in the liver, sitting in the liver cells like balloons, to all the way to this damage or inflammation, to then to scarring, which goes all the way to cirrhosis. And so when we're looking at treatments, and this is what's you're going to hear more about the treatments that come up, and this is an area of hepatology that's exploding, all these treatments. As we look at the treatments, they're really targeted for people that are showing that they're scarred. They're people that are healing by scarring. And when they have a certain amount of kind of moderate or more scarring, that's where these drugs are going to go for. Do they work in people with cirrhosis? We don't know yet, but hopefully they will. And those trials are ongoing. So when you look at managing MASLD, I look at it as a pyramid, or two sort of things. The basic sort of things is trying to focus on the driver of it. And so first of all, it's making sure that if people have diabetes, or they have high blood pressure, or they have dyslipidemia, so they have high cholesterol, or high bad cholesterol, then it's important to treat those. Because of course, if you look at how people die with fatty liver disease, they die of those most, not from the liver problem. They die of heart attack, stroke, and hypertension and things like kidney failure and diabetes. So it's important to optimize the management of those. So get good control of diabetes, get good control of high blood pressure, control the cholesterol. People talk about diets. The problem is that the world is full of diets, and fad diets, as we all know, cycle through, it's a keto diet, it's this diet, it's intermittent fasting. They all are quite meritorious in many ways. Some are not, but many of them are. The problem is that a diet is not living, and eventually you will leave a diet. And the problem with diets is that people do them, but they fail over time. So it's important, if you're going to do a diet, I think as soon as you call something a diet, it's doomed to failure. So it's a viewing foods in a different way. And if you have the financial means to be able to do a Mediterranean diet, I would move to that, which is more sort of non-red meat, fish, poultry type protein, vegetables, high fiber, using olive oil in your cooking, these kinds of things. That's the components of Mediterranean diet, trying to cut down carbohydrates. What about the pharmacological therapies? So there's a lot happening right now. I'm going to talk about some of these that are really closest to what we're to being used in the clinic. So as I mentioned, these are all targeted for people that have significant scarring. So 2 out of 4, which is kind of moderate scarring, all the way to 4 out of 4, which is cirrhosis. So as I mentioned, I'm going to mention start off with what I think are the 2 medications that are closest to being used. One we're already kind of using, the other one we are not using quite yet, but we're going to be using it hopefully soon. And this drug called resmetirom. So this drug actually came from a knowledge that when people's thyroid is not working properly, hypothyroidism is very common in society, they're actually prone to getting fatty liver. So there was somehow an association between that. And 2 people at Roche decided, which is a big pharma company, decided that this drug, resmetirom, showed promise, but Roche did not see that. So they actually took that drug and bought it from Roche essentially, and started to develop it. So it came from 2 people in the lab essentially into a company. And this is why, when I talk about why it's not available in Canada, that's a big reason, because it started as such a small company. And so basically when you look at thyroid, people think, okay, thyroid here kind of helps our metabolism and all that sort of stuff. But the thyroid plays a major role in regulating metabolism in the liver. And there's a receptor called thyroid hormone receptor beta, so that's what the B is. It's actually mainly expressed in the liver. And when you look at the liver disease like MASLD, that receptor number is down. So it's not being stimulated enough because there's not enough receptors there for the hormone to see. So what happens is their idea behind this drug is to actually give a drug that actually stimulates that receptor. So even though there's less of them, it stimulates it more to try to get more action. And so this is a study that was just published in New England Journal of Medicine. And it's basically using this drug in people who have MASLD. They looked at people that had mainly advanced fibrosis. There was a few people with F1, which is mild, but the vast majority of people in this study had two or three out of four, so 4 to 4 is cirrhosis. And 2 is where we start to think about people having serious scarring. And they gave 2 doses or placebo. These studies have to be done with placebos because, of course, we don't know if they work. So if you didn't do it, and I'll show you, the placebo effect is definitely, there is an effect, and it affects the outcomes of these studies. Not so much this one, but one afterwards. And so you have to, when you're developing these, have a placebo. It's demanded by all the health agencies. And so first of all, if you look at NASH, so this is the inflammation that's in the liver that goes along with fatty liver disease. It's improved, okay? So on the left-hand side, that's placebo. So you do get an effect of placebo. So some people do lose weight or do other things to their diabetes. So about 10% of people will have an improvement in that inflammation. But if you see in the ones that got the drug, it's about 30%. So about a 3-fold increase in improvement in the ongoing damage to liver, which is very, very encouraging. If you look at the scarring in the liver, you also get improvement. So this was the first drug to show an improvement in the inflammation and the scarring. All right? And so you can see that the scarring does improve in people that are taking placebo. So if you don't have a placebo arm, you say, oh, I got a 10% chance of improving scarring. That has nothing to do with the medicine, right? That's a dummy pill, essentially. But you can see it's about double the number of people that it went from a 3 to a 2, or a 2 to a 1. Okay, so they've improved by 1 score on that score of 4, which is amazing. Like, this is really, in this disease, this is the first drug to show that. Like this. So to get those 2 components together, I should say this is the first drug to show. Another drug has shown that it had an effect on the scarring, but that drug is not used in the city. The side effects are really diarrhea and nausea, which seems to be a recurring theme in these medications that are used to treat fatty liver disease. And then the drug company is called Madrigal, and so this is March 2024, so just like a month ago, right? They announced that the FDA has approved this drug for use in people with fatty liver disease who have 2 or 3 out of 4 on the scarring part. The problem, of course, is that, as I mentioned, this is a small company. They don't have the capacity to launch a drug in the United States yet. They're trying to ramp that up, let alone in Europe or Canada. And unfortunately, Canada's not second, probably third. And they don't even know how they're going to launch, because they don't have the manpower. So it's going to be a long time, I think, before this drug comes to Canada. But it's coming, for sure. It's already in the States, and they've already figured out how to reimburse it. So it's happened very quickly. So there's also another concept. So that's a liver-targeted therapy. That's a medicine that works on the liver. It doesn't actually attack the disease or the disorder holistically, which means when people have metabolic syndrome, it's a systemic disease. So the other way to approach it is saying, well, can we approach the treatment holistically? Can we look at the whole body and try to treat the metabolic syndrome and hope that the liver will go along with that? So this is the other kind of avenue that's going. So when we talked about this is like targeting all the components of the metabolic syndrome. So diabetes, high blood pressure, dyslipidemia, all the things that go along with that. So there's been a lot of hype about these drugs. They're called, like, everyone knows these are the Ozempic, right? This is the Ozempic, right? GLP-1 agonists, receptor agonists, the drug on the market now is Ozempic. But many companies are developing these type of drugs. I'll talk a bit more. There's also super Ozempics that are coming. And how they work is they prevent your stomach from emptying, So you feel full with the same, and in fact, some people feel uncomfortable because they feel quite full. It also sends a signal to your brain that says you don't feel like eating. So it has two things, right? And in fact, I had a very interesting patient in my steatotic liver disease clinic who said that she didn't think it was really working. She said she was losing a bit of weight, but didn't think it was about 4 weeks into it. And then she came, in fact, we were just chatting on email, and she said, you know, every day for the last 15 years on the way home from work, I always stop to get a Slurpee at the 7-Eleven, every day. So I realized after a month on Ozempic that I hadn't stopped to get a Slurpee once, but I hadn't even thought of it. So these drugs are quite amazing on how they can affect the body, actually. It's quite a unique thing. And this is, if you haven't seen the Oprah thing, I would recommend it. It's quite interesting to watch. You know, she's quite captivating. They also, obviously, how they came on the market originally was to treat diabetes. They're very good at treating diabetes. They're added on there. You usually have to fail other drugs to get on them. But they increase insulin sensitivity, increase insulin release, so they use in diabetes. And then the question is, do they help the liver? Because they're helping this metabolic syndrome. They help people lose weight. They help that they make them more sensitive to the insulin, which is what diabetes is a lack of sensitivity to their insulin. Does the liver get better too? So again, New England Journal of Medicine, and so they did a placebo-controlled study too. And they did people that had MASH or MASLD. And most of these people had, you know, BMIs that were kind of over 30, 35 sort of range. And you know, about 2/3 of them had diabetes, which is pretty common for these studies. And in this particular one, they use daily injections, but of course we know these are typically given weekly. And all the studies since then are weekly, basically. Because they didn't know how this was going to work, that's why they gave it daily. And so this is the inflammation component. You can see that if you compare the ones that have the red box around them. The placebo's on the far right, and then the blue one is the higher dose of 0.4 milligrams per day. And you can see there's a significant improvement in people with regards to the inflammation of the liver. So not only so this holistic approach seems to improve the inflammation in the liver. But when they looked at scarring the liver, this did not reach significant, was felt to be a major disappointment. But this is where I'm going to show you why it's so important to look at placebo arms, right? And this is where and that's why they're doing it in the study. This is only a phase 2 study. If you look at the far right, that's the placebo effect, right? And look at that number. That number in the resmetirom study was 14%. So by having that number on the far right, you get nothing. But if you actually look at the overall outcomes from a scarring point of view, they're the same as the other drug. It's just they're not significant because the placebo arm is so high. And these drugs, of course, what makes them so appealing and why when people do the Oscars, they make comments about people in the audience or whatnot, because these drugs have been grabbed because that people lose weight on these drugs. Roughly 10 to 13% is pretty common. In this study, it was about 13% of body weight was lost on these drugs. So they're very effective at weight reduction. So, as I mentioned, MASLD is a systemic disease. It's not just the liver, like obviously the liver stuff, so that's what I'm interested in. But the question is, I mean, when you look at how people die who have fatty liver disease, they die of heart disease and stroke, number one, right? And they also have a higher chance of getting kidney failure, which ties into all the things that lead to diabetes and prediabetes. And so the question is, if you take a holistic approach like this, can you actually improve those outcomes? And so they looked at that. They've done multiple studies on it. So this one is looking at cardiovascular outcomes in people with type 2 diabetes. And what they showed was there was a profound effect. So then they said, well, what about people who don't have diabetes but are overweight? Does it also improve their heart and stroke outcomes? So this trial is called the SELECT trial, and it was all over the news about 4 or 5, 6 months ago. The reason why is because, see these two lines. That bottom line is the yellow line, the people that got Ozempic. The top line is just the normal. These are cardiovascular endpoints: stroke, heart attack, congestive heart failure, death. And you go, well, those lines don't seem to be that different, right? They kind of just a little bit off, right? That actually represents a 20% reduction in cardiovascular outcomes, which has never been seen in a trial before. So all these drugs like statins that people take like candy and all that, nothing like this. So this drug is now approved in the States almost unbelievably fast for treating people who've had cardiovascular events to prevent them from having another one and dying. So that's the plus of a holistic approach. What about kidneys? So people that have metabolic syndrome are more likely to get kidney failure. So what they did this study called the FLOW study, which I guess fits for kidneys. And they wanted to see, does it improve kidney outcomes by treating holistically in this patient's population with metabolic syndrome? And this study was supposed to be a 5-year study, but they stopped it early because it was felt to be unethical to continue giving people placebo because the drug was so effective. So this drug is very likely going to be approved for preventing kidney failure in people that have metabolic syndrome. So this is the advantage potentially of having a drug that treats a broader metabolic syndrome. The problem with these drugs is that they cause GI side effects, as does resmetirom. But that's the most common cause for people to stop. 10 to 15% of people will stop. And 40% of people, roughly in these trials, get GI side effects, nausea, vomiting, diarrhea, constipation. So what about, can we use these different ways of approaching it to I'm almost done here, to treating, to having personalized care, to this precision medicine for individuals? Well, I think you can, I'll get to that in a sec, but these GLP-1 agonists, like the Ozempic drugs, that's only the first step. This is the first drug that's come out. There's super, I'm sure many of you have heard of tirzepatide, which is, it was all over the news very recently too, because, so Ozempic people lose about 10% of their body weight. Tirzepatide, which are these super GLP-1 agonists, they have other things attached to them. And there's one's called a glucagon receptor agonist, which doesn't really matter. It's just something else stuck to it that works a different way. And people lose 20% of their body weight on those drugs. So these drugs are going to revolutionize how we manage overweight and obesity, and appear to have this holistic benefit on the whole body. So I see in the future there's going to be people that have more scarring in the liver that you're going to want to give drugs that really attack the scarring that are liver specific but don't change the metabolic syndrome. And then you're going to have drugs that are affecting the metabolic syndrome to try to improve all of the outcomes, both not just the liver but also the cardiac and the kidney. They're using Ozempic type drugs to prevent Parkinson's. There's a study came out saying how to decrease risk of Parkinson's with these drugs. So these drugs have multiple effects on the body that's going to be very exciting over the next 10 years to see what they all do. So as I'm finishing off here, you know, I think from a liver point of view, which is a disorder which, you know, if you go back 15 years, we used to say, you have fatty liver disease, don't worry, it's not important, it's benign and nothing happens, to realizing that was a mistake, that there was a small subgroup of people that went on to have significant liver disease, but having no treatments except, please, you know, can you change your diet or change your, lose weight, which is challenging. I mean, when I'm always talking to patients, I say, Oprah Winfrey had the most resources probably of anyone in the world, and she struggled her whole life. So she tried everything under the sun. And so, you know, if someone comes in and says, I've got depression, we don't say, just get over it, although doctors used to say that. We actually give them something to help them. And they may or may not be able to come off that, but their lives change in a positive way. Yeah, the idea that we can't support people the same way with weight loss, I think is ridiculous. And I think we have to change how we approach diet, weight loss, holistic health, and really the key to that is through helping people lose weight. That's my talk.